Okay, hello everyone. Welcome to the second of the Thoracic Surgery Residents Association Journal Club series, which is generally supported by an educational grant from Medtronic to the TSRA. My name is Alex Brescia. I'm the current president of the TSRA and an integrated cardiothoracic surgery resident at the University of Michigan. I'd like to welcome everyone on behalf of the TSRA. I also want to remind everyone that this journal club and the discussion will be recorded, and it's going to be on our YouTube channel and available for viewing afterwards for anyone who's interested. I'd now like to introduce tonight's two moderators. Dr. Samir Herji is a resident in the Joint 4+3 Cardiothoracic Surgery Program at Brigham and Women's Hospital, and Dr. Ketal Mehta, who is a structural cardiology fellow at Yale University.
Thank you so much, Dr. Brescia. It is my honor to introduce our renowned and experienced panel today. First, we have Dr. Michael Mack. Dr. Mack is an internationally renowned cardiothoracic surgeon who is currently the director of the cardiovascular service line at Baylor Scott & White Health System and chairman of the Baylor Plano Research Center in Texas. Previously, Dr. Mack was the president of the Society of Thoracic Surgeons. He has authored or co-authored over 400 publications in peer-reviewed journals and has played critical roles in the Syntax and Partner trial, including the recently published Partner 3 trial. Next, we have Dr. Kendra Grubb, who is surgical director of the Emory Structural Heart and Valve Center and an associate professor of surgery in the Division of Cardiothoracic Surgery at Emory University School of Medicine. Prior to joining Emory, Dr. Grubb was a director of minimally invasive cardiac surgery and the surgical director of the heart valve program at the University of Louisville. Dr. Grubb is a champion of women's heart disease and has also led and participated in multiple clinical trials of innovative cardiac surgery technologies, including studies of Tavr and MitraClip percutaneous therapy. It is also my pleasure to introduce Dr. Michael Reardon, one of my mentors. He is a renowned cardiac surgeon and is currently a professor of cardiothoracic surgery and Allison Family Distinguished Chair of Cardiovascular Research at Houston Methodist Hospital. He holds the position of clinical professor of cardiothoracic surgery at MD Anderson. He has published over 300 articles and abstracts and has been the principal and co-investigator on several industry and government-sponsored clinical trials and research initiatives, including the Medtronic core valve US pivotal trial, the Tavr trial, the Reprise 3 travel trial, and more recently, the Evolute low risk trial. And I'll let Heather continue next.
Good evening, everyone. It's my privilege to introduce the remainder of our esteemed faculty guests tonight. We're very excited to have Dr. Martin Lee on with us today. He is a professor of medicine at Columbia, the director of the Center for Interventional Vascular Therapy and the Cardiac Cath Lab there. And he's also on the executive board of the Columbia Heart Valve Center. He is the founder and chairman of the Cardiovascular Research Foundation and the director and founder of TCT as well. He has over 1,500 publications and has served as a principal investigator of over 50 clinical trials that have helped shape the field of interventional cardiology today. Among these include the Partner trial studying the role of Tavr in patients with severe aortic stenosis, and some of the data from those we'll be discussing tonight. Joining us next from Texas is Dr. Molly Zurlip, who I had the pleasure of actually meeting a couple of weeks ago at the Scottsdale Interventional Forum. She serves as the medical director of the percutaneous valve program at Baylor Scott & White Heart Hospital in Plano, Texas, and she's been there since 2013. She recently became the program director for the newly formed cardiology fellowship there and currently also serves as the chairman of the SCI publication committee. Her specialty and interest in interventional cardiology include structural heart disease, as well as complex coronary disease and cardiogenic shock. And lastly, I'd like to welcome Dr. Shinichi Fukuhara, who is a cardio-aortic surgeon at University of Michigan. He earned his medical degree in Tokyo, Japan, where he also underwent training for general and cardiovascular surgery with intense endovascular experience. Having completed further training in cardiac surgery at Columbia, UPenn, as well as the Cleveland Clinic. He specializes in performing the Ros procedure and has a special interest and expertise in performing complex aortic valve repair. He also has extensive experience in treating failed bioprosthetic aortic valves and has been a pioneer in surgical explants of Tavr valves. So we will now start our first case presentation for the evening. We have Dr. Laura Flannery, who is a structural cardiology fellow at Mass General, and she'll be walking us through the first case now.
Great, thank you so much for having me. Let me see if I can share my screen here. Huh. Sorry, it's giving me a error message.
What's it saying?
Saying I have to give it permission to share. Hold on. Does that one of the panelists that I sent my slides out to, do you want to pull them up as I see if I can get this? I haven't had this before.
Are you on a Mac or a PC?
I'm on a Mac.
You got to go into your system preferences and into security privacy. And you have to unlock and you have to give permission to share Zoom.
To share, so if I click.
It is good to see my generation getting out computers.
I know, I swear I use Zoom all the time.
It's only because I've done the same thing.
So it says quit now.
You want me to, I can go ahead and share your slides.
Can you share my slides?
Sure.
Yeah, I just don't want to lose anything. Sorry about that.
Yeah. All right, let me know if that's working.
Yeah. All right. Thank you so much, everyone, for having me. My name is Laura. I'm one of the structural interventional cardiology fellows at Mass General. If you could go forward to the next slide, I can talk about our first patient. So my patient here is a 73-year-old man. He has a history of severe aortic stenosis, hypertension, hyperlipidemia, prediabetes, and he presented with a complaint of progressive dyspnea on exertion and some fatigue that had been occurring over the past year. He said about last December, he noted while he was playing pickleball at the Y that he would need to rest after playing 2 sets. So pretty active, doing well, but that was new for him. Over the past few weeks to months, it had progressed to the point that he became dyspneic with exertion with anywhere up to 10 minutes of moderate activity doing household chores and the like. And go forward. Regarding the studies that we obtained when we saw him, his echo showed normal LV size and function, normal RV size and function. He had a tri-leaflet aortic valve with a mean gradient of 41 and a valve area of 0.9 and no other significant valvular disease. His right heart cath showed good filling pressures with a wedge of 12 and a cardiac index of 3.3. He had no CAD on his coronary angiogram, and we calculated his STS score to be 1.7. Next slide. These are the Tavr protocol CT measurements that we obtained, which show no concerning measurements. He had good coronary ostia heights. He had good sinus depth, good area, good STJ height and diameters. And you can see a short of the valve there. Go forward. And here is his arch. He did have a mildly dilated ascending aorta, no calcification. And next slide. Iliofemoral anatomy was reasonable with no calcification, minimal tortuosity, and good diameters. Bifurcations were reasonable on the right, a little high on the left. Next slide. His EKG showed that he was in normal sinus rhythm. He had no conduction abnormalities. And next slide. And that's the case. So with that patient, 73-year-old STS score of 1.7, we wanted to ask, how would you proceed with deciding Tavr versus Tavr?
And so what we plan to do is I'll put up a poll question that all the panelists and the audience can answer, and then we can discuss it after that, depending on what that shows. So you should see it pop up on your screen. Go ahead and vote on what you would recommend for this patient.
So you're not gonna give us more information as one of our choices, huh, Alex?
You could ask Dr. Flannery for more information. She may or may not give it to you.
First, you have to tell us what pickleball is.
So it's a combination of, I had to look it up myself, of tennis and racquetball and table tennis. Apparently it's a great sport, and the New York Times says it's the best pandemic sport.
It looks like he's in Margaritaville, so it looks like he's doing good.
Right, yeah.
He's in Daytona Beach, so.
All right, let's give a few more seconds. Votes are still coming in. All right. So looks like definitely split. Looks like about a quarter of people kind of towed the line saying either Tavr or Tavr, but the other would be okay. And then the largest percentage said let the patient decide. Any thoughts from any of our panelists on this case?
So Alex, is this poll of all the participants or just the panelists?
It is all of the participants and the panelists, yes, and about 60% of people answered, 60 to 70%. Yeah, so this is going to be mixed between panelists and audience members.
And the audience is all surgery trainees.
Not necessarily. This is a collaboration with the ACC fellows, so it could be cardiology fellows or surgery trainees. Could be either.
So Laura, tell me if I missed it, but I don't remember seeing anything about his coronary status or subvalvular calcification.
No coronary disease, and there was no significant subvalvular calcification. I should have included that. Thank you.
It's an ideal candidate for Tavr, Mike.
No. Yeah, but it might listen, Marty, as a heart surgeon at my place, this guy's going to be getting a Tavr. He's an ideal candidate. He's in that middle group of the ACCA lines. And, I tell him either one will fly. I mean, we can operate on this guy with a very low risk, or I can do a Tavr and you go home the next day. Take your pick.
But, the respondents are right on. Basically, 85% said that they could have either Tavr or Tavr, basically.
Yeah, I could.
Which is essentially, the correct answer. You can, tilt in one side or the other, but I think either certainly would be, very reasonable in this guy. He is the prototype of the people that were enrolled in the low risk trials.
Yeah.
So he's 73. He's got an STS score of 1.7, which means that he's got a life expectancy. If you're 65 and a male in the US, you've got a life expectancy of 19 years. So he's 73, but I'm guessing he's going to need 2 procedures. So this is supposed to be lifetime journey. So he's going to need 2 procedures, I would imagine.
Maybe. I mean, his statistical survival as a man is about 12 years now. Who knows?
So I think it would get more controversial if this guy was like 63 or 65.
Yeah.
So
on that note, what other features may potentially lead us more towards surgical AVR? We mentioned age as potentially one of them.
So let me give you an example of another case that we just saw last week. Exact same age, 73 years old, STS 1.2, almost identical. The only difference is the patient had a bicuspid aortic valve.
Yeah.
Some eccentric calcification, but not particularly heavy. Ascending aorta was 4 centimeters, no LVOT calcium. He's a retired veterinary professor. He was actually seen at Dr. Reardon's institution, and they recommended Tavr. He was seen at UT Southwestern, and they recommended Tavr. He got a distant consult from the Cleveland Clinic, and they said, come on up and we'll decide when you're up here.
Yeah.
So we saw him, and he was low risk and bicuspid valve, all other things being equal. We said surgery. And he said, fine, I'll do whatever you recommend. So this is a perfect patient that brings out all these issues. Except as we were about to walk out the door, he said, so how long will I have to stay around after surgery in the Dallas area? Because he lives in College Station, which is 150 miles away. And you said, a few days afterwards, why? He says, well, I've got nobody to take care of me, and I'm the only caregiver to my 95-year-old mother who lives alone 2 blocks away from me. So we changed the decision to Tavr at that point, and Molly, we're doing him a week from Friday as Tavr. So
Yeah.
I think this is a factor where, what matters to the patient most when you've got 2 options that are most equal, is what, the deciding factor was, at least for this patient.
Well, I think you bring up a good point, Mike, because especially with the low risk patients, I think it takes a lot more thought, because now you're taking into consideration really the anatomy, because there are some patients, as you just sort of mentioned, low risk patients where anatomy makes Tavr much more risky than Savr. And then there's also the patient themselves, like you just said, when you have somebody who's a primary caregiver and they're by themselves, that definitely has to play into this situation. So for me, I think the low risk patients are sometimes the hardest patients to decide what the best treatment strategy is.
And I couldn't agree more, Molly. I think that the time and effort that goes into consenting and informing a low-risk patient about their options can ruin a valve clinic. Because it's not a simple discussion, and it's all of the clinical factors, and that bicuspid case is a perfect example of a clinical situation that really was the determinant. I mean, for bicuspids, in my mind, I think a lot has to do with the anatomy. I mean, there are ideal bicuspids. I mean, there's the perfect Sievers 1 right-left fusion with nice symmetry and no calcification in the outflow tract, and not heavily calcified leaflets that you're going to get a perfect Tavr. But then there are the other bicuspids when it's going to be a long day in the lab. But the clinical factors are really important in the low risk patients. So this whole issue of shared decision making that is I use that term very frequently. I must tell you, it's probably overused and not well understood. It's not such an easy process, but the anatomic factors in the low risk patients are also key. Obviously, they've got to have transfemoral access. Obviously, the valve has to be, and the valvar complex has to be very well suited to Tavr. So many bicuspids are not going to fit. Patterns of calcification won't work. Aortopathy, mixed valve disease, severe coronary disease, all of those really put you into a category where surgery is going to be better. So you're really looking for the more ideal patient to offer Tavr in younger people as an equivalent or preferred option to surgery.
And I would say it even goes one step beyond that, because once the patient's in the heart team discussion, it goes beyond just can we do Tavr or can we do Savr, but also what valve platform do you choose for this specific patient? Because as we mentioned, we're going to put 2, and if they start in their 60s, potentially 3 valves in. Where are we going to start and how are we going to build on this also becomes a key component of the shared decision making. Not that the patient's going to be deciding which valve, but this gentleman needs to know what are his options for valve 2.
Yeah, so I think, when you're in a situation like this, that you've got 2 good options, then it's the local anatomic features. And if there's still 2 good options that are roughly equal, then it's what's important to the patient and the shared decision making, which we all check the box and say we do, but here, we've been always strong proponents of it, and we almost missed it on this guy. You know, we were.
We talked him in Houston before we sent him up to Dallas.
Yeah. But then what you get into is the lifelong management of a patient with valvular heart disease. And like Kendra says, you're not thinking what this operation is, but what the next one is, and the next one after that's going to be. So those are all the factors. And if this patient goes to surgery, you have to make sure that you put a large enough surgical valve in. I mean, it should be a minimum of a 23 and preferably a 25, so that when that patient gets a valve in valve 5 or 7 or 10 years from now, or hopefully longer, but when they do, you can get a good outcome from a valve in valve.
Along those lines, how do you decide? I know with the most recent guidelines, the age cutoff on when to start offering bioprosthetic valves or mechanical, we've decreased, and you know, it's a lot's been about patient discussion. Personally, when you guys counsel patients, what is sort of your age cutoff beyond which, you know, offering a bioprosthetic valve from the get-go is sort of, maybe you hesitate on doing that?
So I'm still looking for the next patient that's requesting a mechanical valve so that they can take anticoagulation.
Yeah, I mean, Heddle, my rules are if you're under 50, I tell you you should have a mechanical valve. If you're over 60, a tissue valve. Between 50 and 60, the 20-year survival is the same. It's a trade-off.
Okay.
But I'll give you an interesting case that I saw in clinic this week. 49-year-old man. 9 years ago, he had AI, a bicuspid valve, and a 5.2 centimeter aorta, and a young surgeon in Florida who's a really good surgeon said, I'll repair your valve. The repair didn't go so well. He got a 23 pericardial valve and his ascending aorta done, so he got a wheat operation. Now he's back and he's got severe aortic stenosis of his bioprosthetic valve as a healthy 49-year-old. And he refused a mechanical valve the first time. He refuses a mechanical valve now. He will not. So if I have to operate, I'm going to put another tissue valve in a 49-year-old. He's got excellent anatomy for a transfemoral valve and valve. No coronary disease.
In that guy, can you do something like a Ros, even though he's already had, or some sort of homograft?
Well, you can, but homografts, you don't want to do a homograft. You're going to do something, you do a Ros.
A Ros.
Homographs, I really have gone. I used to do a bunch of them. I don't do many homographs anymore.
So what about doing a Tavr this time and fracturing? And then when he's, what's that make him 60 something? When he gets his sternotomy?
That's exactly what's going to happen, Kendra, because we sat down and went over the options with him. And, you know, at 49, if I put a tissue valve in him, he's going to it's going to wear out in your 60s. Now you probably need 2 more operations. Or if I put a Tavr in here, and then we can talk about the risk of going back in. I've done 16 Tavr explants now. But if there's already a valve in there, it's pretty easy because it gives you something to cut out. And then when he comes in his 60s, then we're going to operate on him. And he understands that you are going to come back and you're going to get surgery if you live long enough. But he absolutely, I said, you should get a mechanical valve. And he said, no way, not going to have it. I refuse to take Coumadin. Can't make.
So one of the concerns in low risk patients is the subclinical leaflet thrombosis. And this is seen in all biologic valves, but more commonly is detected in Tavr. So what is the clinical significance in this patient, for instance, who undergoes Tavr? And how would this impact his overall strategy for anticoagulation, if so?
So we anticoagulate all our valve and valves. Mitral is longer than aortics, but they all get oral anticoagulation. You know, what does this mean long term? Samir, I quite honestly don't know. When the low risk Evolut valve thrombosis data came out, my first thought was, oh Lord, what am I going to say about this? You know, I'm sure Marty and Mike had kind of some of the same thoughts because everything was all over the map. It occurs. I don't know what it means yet. And, you know, and do I think that's going to lead to faster, you know, as long as I can get good hemodynamics, I'm actually pretty happy in this guy, and we will. I mean, he's got a Carpante Edwards. It's a breakable valve, you know, so he'll do fine.
You know, the FDA's gotten somewhat obsessed by this, you know, imaging observation, and they've insisted on having a whole series of sub-studies. So there's a lot more data, and there will be a lot of data, which is good. But at least the data that's thus far been accumulated and reported it doesn't easily inform clinical decision-making. So if you look, for instance, at the CT sub-study that was done as part of the PARTNER 3 trial or as part of the Evolute low-risk trial, at 1 month, it is true that halt or hypoattenuated leaflet thickening was more common with TAVR than surgery. But now the patients were blinded to the results. And no anticoagulation was offered in patients that had halt at a month, unless there were other reasons like an elevated gradient or symptoms, which was rare. If you wait until a year and redo the CT scan, half the patients that had halt at a month didn't have it at a year. And this is without anticoagulation. And 20% of the people who didn't have it at a month had it at a year. And if you look at the comparative frequency of halt between surgical and transcatheter valves, there was a numeric difference. It was about 20 versus 27%, but it was no longer even statistically significant. And there was no way to associate the imaging appearance with clinical events. It was uncommon to see elevated gradients associated with halt. There were some patients, but not like what you see with full-blown valve thrombosis. So this is a curious imaging finding. Maybe it'll be a form for accelerated structural valve deterioration in some patients. And we'll follow these patients out for 5-10 years and we'll find out, again, an answer to that. But at least right now, systematic CT scans without a reason are not indicated, and certainly reacting to halt in the absence of symptoms or significant gradient elevations would be a mistake. Systematic anticoagulation is a problem. I think you can give it for a short period of time in valves, but that's not what we recommended. In fact, 2 of the strokes that occurred were hemorrhagic and associated with anticoagulation in the low-risk patients between 1 and 2 years.
So Marty, I'm gonna put this guy in Coumadin for a month. What would you do at Columbia?
It depends. I think Isaac would also do the same thing. For a young person like this, yeah, I think that's totally reasonable.
Yeah, we put them on for 3 months
Well, I
and
did
then
one for 3.
stop it.
Along similar lines. Oh,
Can I comment about something quickly about the Ros procedure in this patient?
Yeah.
Yeah, I think the Ros procedure is definitely one attractive option on this patient, and then even in the redo setting, it is definitely doable and it works great. I just did the Ros procedure in redo setting this morning as well. This was the 5th Ros procedure over the past 2 weeks. And it works great in these younger patients, even like in failed bioprosthetic valve settings. So I just want to make sure that I comment about this.
So I want to comment on that, Shinichi, because if he gets a Ros, he's going to come someplace like you, because I did a bunch of them in the 90s and quit. And I think one of the biggest problems we have is part-time Rossers trying to do a Ros here and there, as opposed to people that have dedicated part of their practice to it. So if he comes up to U of M and sees somebody like you, or comes up to New York, sees Paul, then I think that's a reasonable thing to do. But right now, I tell you, there's nobody at my institution that I'd want to do a Ros on this guy, because there's nobody at my institution that is focused on the Ros.
I see.
Right. For the interest of time, we can have Laura finish the case.
Great. You can go to the next slide. And so after having discussions with the patient, he preferred Tavr. So we proceeded with that. It was Mack TTE guided right transfemoral Tavr. We used a 26mm Sapien. We used his right radial as his second access, given that high bifurcation on the left. The valve deployment went well with no gradient and trivial PVL afterwards. He did have transient widening of his QRS. We left a temp wire in place. It resolved. He was sent home on mobile cardiac telemetry. Next slide. And in follow-up, he was doing well. He said he had improved, his breathing had improved. He was back to playing pickleball. His access sites were well healed. He did not have any events on his mobile cardiac telemetry. We had him on DAP for 6 months, and his echo showed a well-seated valve. The mean gradient was 17, no PVL.
So did his pickleball game get any better?
I should have asked that. Yeah, I bet it did.
I could be a
So
reason.
Laura, I've just got two additional comments. If you look at the role of DAPT afterwards, there really isn't any evidence that DAPT is any better than single antiplatelet therapy with aspirin alone. We kind of did it, reflexly, because that's how you do manage coronary stents, but we've gone to aspirin alone because there's no evidence that dual antiplatelet therapy is any better. And you also see that he had a mean gradient of 17. And I think first you worry about that a little bit. And then there's this whole issue of echo invasive discordance. And that based upon the profile of the valve that you have, a calculated gradient by echo doesn't always correlate with a invasively measured gradient afterwards. And so that's an area that's a very timely topic of discussion right now, is gradients after both surgical valves and Tavr valves.
So Laura, what was his DVI? That's to me a much better way to follow prosthetic valves than either EOAs or sometimes even gradients.
That I do not have. I apologize.
In my lab, until we started core valve, wouldn't even report an EOA on a bioprosthetic of any kind of surgical bioprosthetic valve, that only DVIs. That removes measurement errors of sizing.
That's good to know. Yeah.
But even DVIs, Mike, I mean, I think that's where this whole controversy sort of lies. I think the whole measuring gradients and or measuring just in general with echo is fraught with all kinds of problems, because you're assuming all these equations that were never meant for any type of valve other than the native valve. And so I'm not sure even indexing it helps get rid of that error. And I think the reason why you know this is because even though there's huge differences in the gradients between the self-expanding and the balloon expandable, there's no yet long-term or there's no yet data that says one's better than the other clinically at the end of the day. And so I think until trials like Lighten and stuff like that comes out and we really figure out how to follow these valves, I don't think we're going to really be able to answer that question.
Yeah, we have a lot of data to work on, Molly. I mean, remember, PPM is patient prosthetic mismatch is based on 65 patients. We've repeated P-Rose work with all the data from the Valus trial, and there's no longer an elbow in the curve; it's a straight line. So
yeah, but I mean, we don't even know how to calculate, right? Because all of those are based on derived equations, and those derived equations were never meant for prosthetic valves. They were only meant for native valves. And so we're taking assumption upon assumption upon assumption to get the answer. And, it gets way over my head. You need like the Paul Grayburns and the Zoe Wongs and the Dee Dee Wangs to explain it. But
not only that, Molly, it's a native valve with stenosis.
Yeah, exactly. So it totally, like, we're taking so many assumptions. But I wanted to say that something that we didn't talk about with the low risk patient that also needs to be thought about is those low risk patients that have, say, right bundle branch block. I mean, we think about those a little bit more, doing a lot of the stuff on the tricuspid side. I mean, putting a pacemaker in a 65-year-old because of a Tavr, because of Tavr, scares me, because I see the long-term effects on a lot of pacemaker leads across the tricuspid valve, and then you have a whole nother can of worms, So if you have a better chance of not getting or the need for a pacemaker in a surgical, with surgery, then sometimes I think that may be better as well.
Great. So I'll introduce Dr. Sophia Alexis now. She's integrated surgery resident at Mount Sinai Hospital, and she will lead the second case.
Hi, thank you so much for the honor of being here tonight. Let me pull up my slides. 1 second.
Sophia, David will let you talk about aortic valves. He doesn't make you talk about mitral valves all the time.
we go back and forth.
I won't tell David you're talking about the aortic valve. I promise we'll keep it between us.
Okay.
Yeah, we
I
thought all
just-
the aortic valves went to Columbia and all the mitrals to Mount Sinai.
All right, let me pull this up. All right, can everyone see that?
Yep.
Yes.
Okay. So this case is actually going to be for discussion of reduced Tavr versus Tav and Sav. So this is a patient, 84 years old, very functional with a past medical history of hypertension, hyperlipidemia, peripheral vascular disease, and anemia. She had an AVR and CABG in 2010. She has a patent Lima to LAD. She's been having some dyspnea on exertion for 3 to 4 months. Her exercise tolerance is about a half a block, and she came in with orthopnea as well. STS scores a bit higher than our last patient, 5.7%. She came in with a right bundle at baseline, and on echo, her EF was 69%. She had structural valve degeneration of her 21 paramount. Now, she was a relatively small lady, about 5'3", 130 pounds. Her peak velocity was 4.1, mean gradient of 38, and a valve area of 0.81. The cath showed that her Lima to LAD was still good, and her CT showed that the mammary was clear of the sternum for reoperative purposes. Her carotid showed 20 to 39% stenosis bilaterally. So here's her echo. We can see in the images that her right and her non-leaflet are not very mobile at all. She just has her left leaflet moving. Here is her cath. So she has a non-dominant right, quite large left system. And then in this shot, you can see the patent Lima to LAD. Here's the CAT scan. I show this for the purposes of noticing that the mammary, which is something that we'd want to be careful about on sternotomy, is away from directly underneath the sternum. So for all of our patients, whether we're considering reduced Tavr or Tav and Sav, Dr. Chang has been really great about doing 3 Mentio for all the patients to see, if it'll sway us one way or another. We used Dr. Buffett's valve and valve app, and here you can see what a paramount valve looks like and what a sapien would look like in it. Here is our 3 Mentio workup. So the annular area was 310. The sinuses were a little bit bigger than the valve, so we have about 25 millimeter sinuses. I want you to note, though, that the coronary heights are quite low. So the right coronary was 6.2 and the left was 6.8. This would put us at a size 20 sapien 3 valve or 23 Evolut R. And here we can see that the surgical valve is a little bit canted. We can see coronaries, the left main is quite big below. And here the sinuses are a little bit bigger. What I look at when I do these, the ascending has some spots of calcium. It's not as bad as, closer to the valve. There are spots, we of course do epiaortic ultrasound where one could cannulate, and we'd be careful about our cross clamp selection site. Peripheral access, something we all want to know when we're considering Tavr. So not the greatest femoral vessels and iliac vessels, quite small, but there are spots in the iliac that are a little bit non-calcified, I should say. So I asked the question, what would you do in your practice, a redo Tavr or Tav and Sav?
All right, let me put this poll up before we start discussing. Let's see. Okay, go ahead and vote. This is for all the panelists and the audience members again.
So while you're doing this, did you have the STJ height and the VT, the valve to coronary height, the VTC, distance, VTC distance, and the STJ height.
They're both gonna be small,
Let me-
I can tell you, just looking at it.
So
3.4 on one of those.
They
the STJ information is here. I'm trying to think of how high it was.
Says 15.
There we go. Yep, 15.
All right, so poll results are shown here. Majority of people would do a valve-in-valve procedure, and then a third would do a reduced Tavr. Did any of the panelists choose reduced Tavr?
Yeah.
On off or anything?
I'd have to see this lady first, but this lady doesn't have good femoral access, because I haven't seen her axillars or carotid, which are my other options, but they're probably going to be bad too. She's got coronaries that are at risk just looking at the films, but I want to do my own 3 Mencio before I made any final decisions. And if you're thinking about a balloon expandable and you're going to put a 20 in, you're starting with a valve area of 1.22. So I do a lot of balloon expandables I've never put in and hope I never will put in a 20.
I chose a reduced Tavr. I mean, first of all, if patient can tolerate the reduced Tavr procedure, functionally reasonable. I mean, reduced Tavr procedure itself isn't a difficult procedure, first of all. And her VTC distance is less than 4 millimeters. And very, short sinus of valve height, small STJ. There's no reason to risk the Tavr procedure. If something goes wrong, then we're going to have to emergently open the chest, or patient may die on the table. And if patient has reasonable, function who can, who can tolerate the reduced Tavr, we should do reduced Tavr. We can give her even bigger valve. She may live until like 100-year-old, and then I think giving her bigger bioprosthetic valve plus a bigger STJ diameter is a very reasonable approach.
Yeah, plus Shinichi, she had a pretty easy redo chest. I heard she had plenty of room in there.
Definitely.
I was going to,
Go ahead, Marty.
I just wanted to ask Kendra, you're at the home of Basilica down there in Atlanta. If you were to do a valve-in-valve, would you do Basilica in a case like this?
Well, we didn't get the complete workup for, but what I can tell from this, absolutely. We would split both. As far as I can tell, we'd end up splitting both and do a valve-in-valve. Probably even try to get away with not necessarily fracturing, but remodeling the Tavr valve with a balloon just to try to get the most out of it. But, we do a lot of that here. We need to also look at all of her access, marginal on the left, what's her cable window look like, and what's her alternative access look like. To get back to the redo Tavr though, I really think it's important that we do look at her functional status. 85 is, not the same across the board. And although you can do a quote unquote easy redo Tavr, if she ends up in a nursing home and never going home again, but came in as an active 84-year-old woman, we've made the wrong choice. And so I will say that being at Emory and knowing what we're capable of, with electrosurgery and alternative access, I think that we're able to offer these patients a really good result without committing them to the nursing home.
Molly, you and I have been doing this together for 10 years. Why don't you take everybody through our thought process if we saw this patient together?
Okay, so I will have to say that I had to re-log in, so I missed everything that you guys just said, but I will tell you what we do. So we look at this, we look at her size, we look at her access, her age, what she eyeballs, and then we look at the two different valves that we have and how we could put them in, by carotid or by transfemoral. A small woman like this who's 84, we would try everything we could to do a TAV and SAV. And we would look at the coronary heights, and if the coronary heights were low, then we would do something like either protect or do Basilica. but we would most likely do a Tavr and Sav in this situation.
And if we did a Tav and Sav, we do it with a 23 Evolute rather than a 20 Sapien, right, Molly?
Yeah, except that her coronaries are low and her sinuses are not that big. I think her average sinus was what, a 25?
Yeah.
And if we felt like it's because she was a really small woman. I think you said she was 5'2" or something, and
5'3", yep, 130 pounds.
130 pounds. Yeah, I guess we would try a 23, and if we were going to frack, maybe do basilica or protect the coronary.
Well, first of all, 5'3", 130 pounds is the perfect size for a woman. So
yeah, I know. So it's not small. It's not like a 5'2", 110-pound woman that a 20 inside would be okay.
I was just thinking about what I've been with for the last 51 years. So that.
Yeah.
So Molly, we'd have to see this lady first too. I mean, like Kendra said, there are 84-year-olds and there's 84-year-olds, and then you got to figure out what your coronary risk is. And yeah, if she's not a surgical risk, and then we'd buy basilica this lady. But if you knock off one of her coronaries, she's probably dead.
Yeah.
Since we're discussing in terms of fracturing the valve, can someone just comment, one of the panelists, in terms of how you decide which valves to frack or remodel, and do you tend to?
Yeah, well, there's a chart. So thankfully, the guys at Mid-America Heart, Chachwalala, and those guys, they actually did the bench testing. So they did a lot for us, and there are some rules about as to like how you pick the balloon, and it's different for both Sapien versus core valve. And Mike, we might even consider for this one putting a 20 in and fracking it if we were really concerned about the coronary heights, because she's 84 and she probably would do okay with that.
Well, I do a lot of both, particularly a lot of self-expanding, and I worry about self-expanding with these small sinuses because
yes,
if you put a balloon expandable in, you knock off the coronaries, you do it right then and there, and either you fix them or they die. But I've had self-expandings come up with late coronary occlusion.
Yeah, and in this case, the sinuses are too small, I think, because you would put a 23 Evolute and you need 25 sinuses, and that's right. I mean, I would be worried about the coronary. So I would either do a 20 or 23 Sapien, maybe a 20, because she isn't huge, and frack it or fracture it. Sorry.
Yeah, make those guys mad. Well,
would your decision change with someone who's like 70-year-old instead of an 84-year-old in this instance?
70-year-old with that anatomy, I would lean more towards surgery, I think. I don't know. But yeah.
I think the problem with this case is that I hate both of the choices.
Yeah.
Exactly.
I mean, I just hate the choices. She's 84, and I can't recall when we've, taken an 84-year-old a surgical failure, back to the OR. So you'd really try to work hard to do this as a transcatheter procedure, but she's got horrible access. She's got low coronary. She's got narrow sinuses. If you put a 20 in, I hate putting in a 20 valve, Sapien 3 valve and valve. And you can crack it and you can get, a little bit out of it, but you're not going to get that much. You're never going to be, I don't think you're going to be able to get a 23 Sapien Ultra. Even if you crack it, the sinuses are too small. And if you put an Evolute in, I tell you, there's this, new concept of sinus sequestration, which is very, and she's a perfect setup. She's got small sinuses. She's got, you can shut down a sinus very easily in a case like this when you put an Evolute in.
But sometimes it doesn't happen right then, Marty. It happens the next day. Which
right, which is terrifying.
Exactly. So I just hate the choices. But
I think you should ask her to play pickleball against that first guy. Might solve this problem.
She's got a right bundle to start with. Although we always say valve and valve, you generally don't have issues with pacemakers, but she's exactly the person who'll end up with a pacemaker also. She's got coronary disease, although she's got a patent IMA. So again, this is, a tough case. And I think whatever you choose, it's um, uh, I could defend either side. I think, at Columbia, we'd probably do a valve and valve, but we would do it grudgingly. And it would be after a careful discussion with the patient and a good look at her. I mean, maybe she'd surprise us and she's an 84-year-old that, functions like a 75-year-old, and we would consider doing a surgical redo.
Except for looking at the calcium in the aorta, which is a marker.
Yeah, yeah. No, I agree. This is a
And you
this is a
got
big
you
case.
got the lima protecting the left coronary,
Yeah.
which gives you a little bit of flexibility there. So
That's true.
we really didn't see the carotids very well, but I think our preferred alternative access would be probably transcarotid, although Adam has come from Emory and helped us through some trans cables here. Molly, what would you do for alternative access if the femorals turn out as bad as they look here?
Yeah, so we would, our preferred access first is transcarotid, and then with transcaval is a close second. But, it just seems like every one of our patients that we can't do transfemoral also has a horrible aorta, so we can't do transcaval very well either. So transcarotid is typically our next. I mean, we haven't done an axillary in a very, very long time, and a transapical in like over a year. So
Yeah, so we would probably do axillary in a case like this. I mean, obviously we'll look at the anatomy carefully, but that would be our preferred alternative access. Another procedure that we've done a bunch of, and it's really our surgeon's preference. Isaac George does a really nice job with suprasternal access, which is, kind of a cool way to go. You've got to be familiar with using long instruments, so it really depends on your surgeon's skill set, but it's really a direct engagement into the base of the innominate. So that's another choice. And now David Cohn has recently joined us, and he's pushing us to do more transcarotid. So, but I think any of those, the key thing is you've got to be familiar with the procedure, and you've got to do enough of them so you do it well. So I hate to dabble. We've done some cables, but we do a handful. You count them on the fingers of one hand over the course of a year. You never really get good at it, which is why we really put that way down on the list.
yeah, I will tell you, we were reluctant at first to do transcarotid, and now it is awesome. It is like our transfemoral. I mean, they go home, they do great. And it's a quick procedure. It's right there when they expose.
Yeah. I usually go femoral, actually carotid, but we do a lot of carotids. I think they're great, Molly. What I would tell this lady is that Plano is beautiful this time of year.
You laugh, but these are the ones you see. I feel like these are the standard valve and valves that you see. I mean, I love it when we have an easy valve and valve.
No, this is
Tough
one of
case.
those cases that I-45 is a one-way street north to south, Mike.
Yeah.
So Sophia, what'd you end up doing?
Okay, so I'm a cardiac surgery trainee, so that's my bias. So I think she is like perfectly reasonable for a reduced Tavr. She passed the eyeball test, even though she's losing pickleball to the first patient. But what we did end up doing is a TAV and SAV. So we brought the patient to the hybrid room. We did it with more precautions: general anesthesia, TE, full surgical prep, chest exposed. We obtained percutaneous right femoral artery vein and left femoral vein access. We cannulated the left main, wired it, had a stent in place in case we needed it. And we actually did what we do at our institution occasionally, which was an approach not discussed, but we did external iliac access. So we made a cut down in the left lower, got proximal and distal control of the left external iliac, put in the 14 French delivery system, crossed the valve and did a 20 Sapien 3. Then we confirmed that we had coronary patency, and we removed the stent and repaired the iliac in the soft spot where we were able to put in the delivery system. This is just proof of concept that that Limita LAD was not going to fill any of her left-sided system. There's no retrograde filling, and her circ would have been completely taken out with balloon occlusion of the left main, just for proof of concept. And here we can see our valve deployed and our coronaries being filled.
I'm sorry, so you didn't crack the surgical valve?
No. No, and here is our echo with mean gradient of 14, no PVL. We extubated on the table and she went to CCU. We had her on aspirin and Plavix and she was discharged post-op day 2.
And didn't need a pacemaker.
No.
Great outcome.
Good result.
That is great. So now I'll introduce Dr. Bracia to go with the last case.
Yeah, I was just gonna, I just saw Dr. Tang raise his hand. So let me just.
Hi, sorry guys. I just finished that case. I just want to say this was one of our cases with Sophia presenting it. To Marty's question about cracking, we were just worried if we cracked, unpredictable nature may end up occluding the left main. That's why we're just conservative about that.
Gilbert, I'd say once you got that valve in there, if it looked good, you should look up and thank God and move on.
Completely agree with you, Mike. Less is more sometimes. We actually had one case where we tried to crack and damage the S3 and they were put an evolute in afterwards. It was not pretty.
Yeah, that's not too common though, Gilbert. And some people are systematically cracking, and so I don't think it's as unpredictable as you're suggesting.
The only thing that bothered me about this particular one, Marty, is just how close the coronaries are. I'm not worried about the crack.
Yeah.
I'm worried about the coronaries.
Yeah, no, I agree.
Yeah.
Well, the left was protected.
Yeah.
Anyway,
on that
look,
note,
look,
had the final gradient been say more than 20, would you go back and track it at that point or just leave it? Or
yeah, we don't crack before. So we don't crack everything, obviously. And a gradient of 14 with a 20 valve is probably as good as you're going to get.
Yeah.
So I think I certainly have no problems leaving it alone.
All right, so I'm going to present the last case. So far, we've talked about the initial low-risk patient, a patient who comes back with a failed Tavr, and so this is a patient with a failed Tavr. So a brief history, this is a 77-year-old who had a 29 evolute put in for severe aortic stenosis 5.5 years ago. He presented with new onset stage or class 3 symptoms, including chest heaviness and dyspnea on exertion. And prior to that, he had been completely recovered and active and walking 3 to 4 miles a day. So that initial Tavr procedure, his predicted risk mortality at the time is 3.4%. I'll talk a little bit about his history, but he was deemed high risk by our Tavr team due to the history of liver disease, chronic kidney disease, and immunosuppression. He had a 29 core valve evolute, as I mentioned, and his immediate post-procedure TEE, he had mild to moderate PVL at that time, and also had severe MAC of his mitral with mild MR. Day 1, his echo, he had mild PVL on the surface echo. His gradient was 15, peak gradient was 26, and moderate mitral stenosis. And again, this is 5.5 years ago. And the only other thing of note is on day 1 after that Tavr procedure, he also had a pacemaker placed for 2nd degree heart block and a new left bundle branch. So notable past history, he had primary sclerosing cholangitis, and he had a liver transplant 18 years ago. And that goes to what I was saying about him being deemed high risk despite being low risk by STS score at that initial Tavr. He also had severe MAC, hypertension, hyperlipidemia. He was a diabetic managed with insulin, but had a reasonable A1C of 6.7%. Stage 3 CKD with a creatinine of 1.6, as well as ulcerative colitis. And so the workup we got included a Tavr CT, and this is again presenting 5.5 years after that Tavr. We got a Tavr CT, surface echo, left heart cath was not notable, and he did have some carotid disease. I'll show some of the imaging after this, but altogether his risk at representation now just for isolated Tavr was 7.8%. Mortality and morbidity was 26%. And then one of our surgeons working him up had said an additional 5% for the liver disease. So this is an important image from a CT scan, which shows a lot of what we've been talking about in terms of his coronary to valve heights which are actually quite high, 14 on the left, 15 on the right. His conditional height's 26. His STJ was 25 millimeters, and that's something that we'll come back to later. And again, this is with a 29 Tavr valve in. So this is echo on the left. You'll see his Tavr valve, and then you'll see the jet of PVL, and then, oh, sorry about that. And on the right, this is his mitral, and you can see that he has moderate to severe mitral stenosis as well. And so now I'll put up the poll question in terms of what you would offer this gentleman. Go ahead and ask any questions that I didn't touch on.
Well, yeah. So what was the reasoning for the high gradient across the valve, across the aortic valve? So you didn't have leaflet immobility, the leaflets are moving, so it's PPM?
No, he's got also a combination of high flow, Molly. I think he's got more than mild PVL, so he's got probably a pretty big stroke volume. You know what his stroke volume index was?
Yeah, that's what.
Yes. So do you mean at the initial Tavr or at
right now?
No, now.
Molly's asking.
Yeah, 78.
What is it?
78.
78. And so how big is the guy?
He's a small guy. He's 5'9", 130 pounds. BSA is 1.7. BMI is 19.
That's a fairly significant stroke volume.
Yeah.
And did his mitral stenosis change from the first Tavr? His mean gradient was 7 the first time. What is it now?
His mean gradient now on this surface echo, it was 9, and then on a subsequent echo associated with the procedure he underwent, it was 11.
What was his heart rate when you got those mitral gradients? Remember?
His heart rate.
I mean, I'm worried about his mitral valve as I am his aortic valve.
Yes. Yeah. Yes.
I mean, I think if he just fixes the aortic valve, this guy's still got a bad problem.
Absolutely.
Have you done a TE echo, or was that echo a transthoracic echo?
That echo is a transthoracic echo. So we did not do a TEE prior to making a decision on the intervention.
I would absolutely want a TEE to look better at the mitral valve as well as that PVL.
Yeah, so I guess an alternate question to this poll question is, what would you do in the absence of the mitral? Obviously complicates things. So I'll go ahead and move on here in a minute. I'll give people a few more seconds.
Kind of like the last case. Don't like any of the options here.
Yeah. What did you say the mitral gradient was? I'm sorry.
9.
That
9.
Okay.
But I don't know what the heart rate was. So yeah, I'm not really sure how. I mean, it's bad, but I don't know how bad. But
yeah,
the word liver, you lost me, because the word liver, I start trying to find excuses
not to do surgery. Absolutely. This guy doesn't have that big of a life expectancy anyway, does he? He's 18 years out of a liver transplant.
He's 18 years out of liver transplant. He's 77 years old at presentation. But again, he walked 4 miles a day until a few months ago when he started really getting symptomatic.
And the mitral stenosis is from Mack, correct?
Yeah.
But yes. It sounds like, yeah.
But he did have severe Mack 5 years ago at the initial Tavr as well. But he had mild mitral stenosis, mild MR at that time. All right, so here are the poll results. This looks like about half of people said Tavr explant and replace the mitral. And then another quarter said to do a redo Tavr and observe the mitral. Any thoughts from the panelists in the direction of?
The only thought is on that top one, mitral valvuloplasty, just scratch that off. Please.
Yeah, absolutely. Yeah. But I don't know why you would. So first off, the Tavr valve is working. Yeah. The Tavr valve is working. So you have to figure out why.
Well,
well.
Yeah, so I went, sorry, let me go back. I went through a little quick on the Tavr valve is not not exactly working. So he has a gradient of 30 across his Tavr valve.
Yeah,
Right,
but they may all
but
be.
the leaflets,
I mean, he's got
right, but the
liver disease,
leaflet,
he's got AI.
The leaflets
Exactly.
are
Are moving.
working, but they're severely calcified.
So we missed that part.
Yeah, he did not have, so the CT was mainly obtained to see if he had halts, which he did not, but he did not have any restricted motion. As you can see, he did have severe calcification.
I would be looking for reasons to delay his surgery, so I'd get a CMR on this guy. And I really want to know are my echo number is really true.
Well, I'd start with the TE echo and get a better
Yeah,
assessment.
I'd definitely get a
Yeah,
You know, how severe
Yeah.
the PVL is, make sure I understand what the valve
exactly.
pathology is.
And I'm hoping on my CMR it has amyloid, so that I have a reason not to.
Yeah, there you go.
I mean,
So if I was a surgeon, which I'm not, but I mean, in a liver patient like this, to do a double valve with it being Mack, I mean, that seems a lot, right?
Yeah.
My surgeons.
What did you choose for the choices? Would you observe or what would you opt for?
I would do a TEE. See, I'm hedging because I don't like any of these options either, but I want a TEE to know, because if it's just because of high flow and you did a PVL and it was all because of, like, you know, severe AI or something, then you can fix that. And then you could address the mitral if the gradient's still high. And if you walk the guy and see on exercise that the mitral gradient goes even higher, then you could do, you know, a mitral valve in Mack, or I don't know.
Right.
You know, something like that.
All right.
I wouldn't do a double valve though.
So that is what we chose to do. And a couple of points before I get to that procedure, but the contraindications as we viewed it to pull this up. The contraindications to redo Tavr were first something that was mentioned earlier about a sequestered sinus of Valsalva. So this guy had great coronary heights. I think they were 15 and 16, but his STJ was narrower than both the diameter and the height of his Tavr valve. And so that was viewed as a contraindication to doing a redo Tavr from our group. And a second point that also was made later or earlier about this, and something that some people at our institution do, including Dr. Fukuhara, whose patient this is when doing a Tavr, so unrelated to this patient, but when doing a Tavr and doing a root enlargement, he does kind of a lazy S so that there's a longitudinal aspect of the incision through the STJ, so that the STJ is also enlarged to prevent this exact problem and make that patient more amenable to a valve-in-valve procedure down the line. The second contraindication is the mitral valve disease, which we've sort of talked about pretty substantially at this point. I mentioned the gradient was 11 and the intraoperative TEE once that was gotten, but at that point we were already in the operating room for the procedure. So the operation, again, this is Dr. Fukuhara's patient, but you'll see, so this is just taking the valve cage off of the intima, which was pretty severely adhesed after it had been 5.5 years, as you would imagine or have experienced. I know Dr. Reardon, you said you've done 16 of these.
Interesting enough, I would have thought the self-expanding would be harder, but I found the balloon expandable harder to get out. I don't know why.
Yeah, I'm sure. And that's interesting. Yeah, I'm sure Dr. Fukuhara will have some comments on that.
And while we're watching this explant, any experience with, in this case there was PVL, but removing just the leaflets and doing a TAV and TAV?
Yeah, so I'll let Dr. Fukuhara answer. But we've actually more often we've done actually a surgical valve in valve. We have a number of stentless routes actually that have been done, freestyles. And I know that is one thing that Dr. Fukuhara has done a number of times is resect those leaflets and then put a magnet in. So as you can see here, we ended up doing a commando procedure using a 2-patch technique for the aortomitral continuity and the dome in the left atrium. And that's why you see the 2 patches here. And then replacing both the aortic with a 27 magnet and then a mitral with a 25.
So when he looked at
So
the leaflets
obviously
on the, I'm sorry. When he looked at the leaflets on the Tavr valve, what did it look like?
It was actually severely
So-
calcified, and it's not well mobile. So
Okay.
and then, but also I think another thing we should highlight is oh, this is a sequestered sinus of this is a nice image.
Right.
But, so the I think that
Yeah, so-
another highlight is so the surface echo oftentimes underestimate the PVL degree. So for example,
Absolutely.
this patient was also always told as having mild PVL, but in the OR on the TEE, it was moderate to severe PVL. We always see this in patients undergoing Tavr valve explant for PVL reason from a mild to severe all the time. So this is another thing we should keep in mind.
And
So
an MR will really help you there because you can, if you really got somebody that's not doing well and you think they're mild, do an MR and find out how bad it is. You can really quantitate it.
Yeah, it's very hard to quantify PVL, especially with the self-expanding valve, I think.
By echo.
Yeah, by echo. But I think TE would give you, I mean, I guess the comfort of your program or whatever, but I think TE gives you a good idea too of how bad the PVL is.
Gilbert, you're the expert on surgical explant of Tavr valves. What's the overall registry experience?
Well, I wouldn't say I'm an expert. I mean, Shinichi has been contributing a lot to the registry. Actually, we have about over 269 patients across 42 centers in Europe, Canada, and the U.S. It's about 50-50 split between self-expanding and balloon expandable. I would say, the root replacement, surprisingly, is not that common, around 13% in the registry. But I think the issue is going to be a lot of these patients may have concomitant cardiac diseases that require multi-valve surgery, like in this patient. So not a small number of these patients actually had, mitral valve disease or tricuspid valve disease needing surgery. And at the time of the surgery, I guess the aortic valve also needs to be done. So it's interesting. We recently actually had a very interesting case where the patient actually had 81-year-old, not prohibited risk necessarily, but had primary MR that was very repairable. And during the retraction, we had the patient had a previous sapien 3 valve, and we actually during retraction deformed that a little bit, and I had to actually post-dilate it back to a circular shape. So certainly, this kind of situation may happen, and I think it's important to have these kind of tools and considerations available to us.
And then, as Dr. Fukuhara mentioned, this is a picture of the left and right coronaries with him holding the leaflets up to basically demonstrate that concept of sequestration, which would occur if we were to have tried to do a redo Tavr. We'd definitely be at risk of it.
And one of the issues with the supraannular valve is that tube graft goes way up.
Yes, definitely. And on that note, actually, the damage from the valve to the STJ intima required us to basically replace his mid-ascending with a gel weave graft. We did a mitral replacement, as I mentioned, a aortic replacement, and then patched the non-coronary sinus of the root. And so definitely a major operation, as was discussed. These are just some details from the operation. Had significant bleeding afterwards. That being said, he did do well afterwards, considering the operation, and was discharged home on day 8. And at his 1-month follow-up, which was just a couple months ago, he was resuming his daily activities and doing well.
Yeah, outstanding case.
So I have one question for Dr. Fukuhara. You obviously have experience quite extensive with the explants, and obviously the outcomes of surgical explants have been almost like double from just redo Tavr, and as you've shown in the STS and multiple CMS studies. Do you think these outcomes will continue to improve over time, or are we going to see a lot more incidents? Because right now the incidence is around 0.4%. So are we seeing more in the low risk population?
Yes, I think we're gonna start seeing more and more patients, because I think these Tavr valve explant patients are essentially mostly, high risk or moderate risk patients, and then it's been only like a 10 years or a little bit more follow-up period. So it's been not enough follow-up. So we're gonna start seeing more and more Tavr valve explant scenarios. Having said that, I think the dismal outcomes of a Tavr valve explant scenario is, I don't think that's coming from the complexity of the procedure, but I think it's essentially coming from the sickness of the patients needing this procedure. So this is something I think I wanna just mention. I wanna make sure that people understand this. But yeah, so the procedure itself is not as difficult as claimed. And after having done 2 to 3 cases of a late explant, it's actually not difficult. So, and then I'm sure Dr. Reardon feels the same way, but yeah.
I mean, when I look at our series, Shinichi, I've lost 2 people, and they were both people that originally were extreme risk for Tavr and weren't surgical candidates. But then when it failed, they came back and they were surgical candidates. And the surgery went fine, but the patient just never recovered. They died in, both of them died in LTAC. So it really wasn't how hard it was to operate. It's just that these were bad patients that we had no other choice on.
Yeah, I have to agree. And also another important thing, if patient has borderline concomitant mitral disease, for example, or coronary artery disease, and if the Tavr valve fails, those borderline disease will become really severe. And that's another thing we have to keep in mind. And then I think, when for low risk patients undergoing, choosing to have a Tavr, they should be informed of this surgical explant scenario in the future, and that's I think something we should do. I think moving forward.
Along those lines, for the patients that we discussed, so this is sort of going back to that first case discussion we had, in that younger patient who may end up needing 2 or 3 valves over their lifetime. What is sort of then, like, should we start off with surgery first, or sort of reserve surgery as second? And start off at the Tavr first in terms of what we would offer as their doctors.
And then another thing I want to comment is, many people are choosing to have a bioprosthetic valve, and everyone says, oh, you can get the valve-in-valve Tavr. I'm not as optimistic in terms of a Tavr in Tavr valve procedure. Actually, at the University of Michigan, we are seeing much higher failure rate in patient with a Tavr in Tavr procedure. So it's, and then I think, and again, it's not because of the Tavr procedure itself. I think that's because of the surgical bioprosthetic valve being too small to start with. So I think if we are a surgeon who is performing Tavr, offering Tavr, we are responsible for giving patient the best anatomy. And then we really don't want to put like a 21 millimeter valve with a tiny STJ diameter. Patient is not going to be able to have a nice, valve-in-valve Tavr in the future. So I think surgeons are really responsible for this concept. Yeah.
I think Marty will tell you in the low risk trials, surgeons got a little smarter, and as we went down the trial series, by the time we got to lower, surgeons were putting in bigger valves. We got tired of competing against Tavrs.
Yeah, 85% were size 23 or larger, but we strongly encourage that on the front end. And with that, only 5% got a root enlargement procedure.
Yeah.
So, surgeons were still, we asked the investigators on the front end, and surgeons, the majority of surgeons felt that a root enlargement procedure raised the risk of the procedure, which was interesting in and of itself. And but 85% got a 23 or larger in the Partner 3 trial. But if you look at overall in the US of valve usage, 50% are 21 or smaller.
Yeah.
Which is the point that Shinichi was just making. If the goal for putting a bioprosthetic valve in a patient is they can get a valve and valve on down the line, if you put a 21 valve in that patient, you're doing them a disservice.
Dr. Mack, I know, just speaking back on the first case, so 2-year data for Partner 3 shows like a narrowing lead for Tavr in terms of the combined endpoints, and the curves seem to sort of converge. Do you anticipate that this would be a factor as with more follow-up, or how does this change your decision-making process right now, evaluating those patients, given the risk of thrombosis that we're seeing?
So, I would say, there's a couple answers to that. One is, though the Partner 2 was done in a population that had a limited life expectancy. And when you get to the point that a patient's going to live longer than their valve, then that helps, it's a different discussion from that standpoint. Now, because of this, both the Evolute and the Partner trials are following patients for 10 years. And so we will know for the first time what durability is of both Tavr and Savr valves. I mean, we say that surgery valves last 12 to 15 years, but we really don't know that because surgical follow-up has been reoperation-free survival. They have not been followed systematically like Tavr valves does. So, we really don't know, what that ultimate answer is going to be. But the other thing is that I've gone back to this a number of times. If you've got a prox LAD lesion, what's your best chance of being alive and reoperation free at 20 years? It's a lima to the LAD. How many patients choose that? None. So the point is that let's just say that at 10 years, there is a durability difference in favor of Savr. I don't think that's going to matter to most patients because they're going to focus on the recovery and worry about whether they need another procedure when that comes 8 or 10 years down the line. I mean, Mike, what do you think about that?
So first of all, Samir, were you talking about the Partner 2 data or the 2-year Partner 3 data narrowing?
2-year Partner 3.
Yeah. Oh, I'm sorry. I misunderstood you
2-year
there.
Partner 3 is regression to the mean. The 1-year mortality in the Tavr arm at 1 year was so low, it was unbelievably low. It's just regressing to the mean. So it's now looking more like what you'd really expect in that patient population.
Mm-hmm.
So it was just so astoundingly low that it's going to come back statistically. That's what happens.
Yeah, there was catch up between year 1 and year 2 of Tavr to Savr. But who knows what way they're going to go from here.
But I mean, Michael, when you have a 1-year mortality of 1% in the Tavr arm, that is just so low that statistically it's going to have to catch up. If you put a bunch of 73-and-a-half-year-olds in a living room for a year, you'd be lucky. You'd be lucky if only 1% of them died if they were just watching TV. Now, if you showed these old people something like Game of Thrones, maybe a few more would die from stress.
Now careful, Mike. Don't get carried away here. You're talking about our age.
Yeah. But Samir, when I saw that, I did not worry about that at all. That's statistical regression to the mean. It's still at 2 years, it's still an astoundingly low number in both arms.
Mm-hmm.
All right, so we're at 8:25. We ran a little bit over. But first of all, thank you so much to everyone for their time. And I appreciate all the discussions that we've had, and I'm sure all the trainees will enjoy and listening to this. And we look forward to more of these sessions in the future as well.
Well, thank you for inviting us to do it. It was a pleasure to participate.
Yep, absolutely.
Thank you.
Thank
Thank you,
all.
everyone.
Really
Thank you.
appreciate
Thank
it.
you.
Bye-bye.
Thank you.
Night.
Thank you.